Okay. So my name is Rhea Markowitz. If you don't know, I'm from the Georgia Cancer Center, and I'm part of the hub team of our TeleDerm project. And Dr. Doug Patton and I will be serving as co-facilitators of today's session. So I want to start off with an announcement, which is that this TeleECHO, of course, is for the month of May. We have decided to take a summer pause for the months of June and July. So our next TeleECHO session will actually be August 7th. And I will repeat this at the end of today's session as well. So we're going to take a couple of months to organize the future lectures and schedules, and hopefully we would like to bring in some outside speakers for the didactic parts. I do want to emphasize to our teledermatology clinics, though, that we are continuing with the Molescope Derm Engine part of the project. We will be receiving consults all through the summer. So please send in use your Molescopes and send in your consults to us. So I hope everyone has their screens on gallery so we can see each other and that you have your names, the appropriate names typed in. I want to welcome in particular, our teledermatology clinic healthcare providers. So wave as I mention your name is Dr. Sam Whaling from Lee Medical Arts. I'm not sure if I've seen his name check in yet. Lori Hutchins from Mount Vernon is here. Someone. Aisha McFarland from Soperton is waving. Sabrina Watkins from Evans Health and Wellness. Stephanie Cawthorn and Carolyn Jones from Baxley. Floyd Soriano and Phyllis Solomon from Metter. Billy Stout from Sylvania. John Ferrier from Wadley. Tracy Rosenbaum from APHC Edison. And Michael, is it Sign? Is that how you pronounce it? Sign or
Same?
Same.
Yes.
From Dawson. So this is your first time here, I think. So we welcome.
Thank you. Good to be here.
Good. And I want to welcome members of our TeleDerm team who are some here at the hub. So Kenza Mamuni at the controls. Brenda Santiano is traveling, so isn't here today. And Marisol Miranda is here at the controls. And our medical student, Mackenzie Maloney is here at the hub. And I know that we have other team members out there in their offices, Mo Sharara, Helen, I saw, and so we welcome all of you. And then I think we have residents from the dermatology department and so forth. I also, of course, want to welcome our other dermatologists, Dr. Ramirez and Dr. Davis, Dr. Buchanan, of course, and Dr. Diamond, who will be presenting, and I hope I didn't leave anyone out. Remember to put into the chat your full name and your email address and your clinic affiliation or program. I think that there are already a number who have added in. And so I will go over today's agenda to start. So our usual introduction. We're going to have two separate didactic presentations today. Dr. Kendall Buchanan is going to do a continuation of last month's, which was dermoscopy in general dermatology. So we'll get part 2 of that. If you remember, she didn't finish that up. And then we will have a presentation by Dr. Davis Diamond, who's a PGY3 dermatology resident, and he is going to talk about skin biopsy techniques, which should be very useful for, we always talk about getting biopsies, and he'll go through the different techniques. And then we will have a case presentation by Andrea Ramirez, who is a 3rd-year medical student. And then we'll wrap it all up. So I think I will now turn it over to Dr. Doug Patton, who will continue. And as you know, Dr. Patton is Dean of the Southwest Georgia Regional Campus of the Medical College of Georgia, and he has spent most of his career as a rural physician. So Doug, take it away.
Thank you, Rhea. It's good to be back, and good seeing everyone here. Looking forward to an exciting session. We're going to keep it moving today. We'll move through these traditional introductory slides pretty quick. The Project ECHO, as a reminder, is extension for community healthcare outcomes. And so we'll keep moving to the next slide. This goal is to improve knowledge about teledermoscopy and teledermatology through the use of telemedicine and teleeducation. This kind of learning is most effective when we share knowledge with each other. So please, 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 if you have questions, please put them in the chat during the presentations, and hopefully we'll have some time in between presentations for folks to actually ask their question. Next slide, please. As mentioned, these sessions are recorded, and it's important for us to remember that this is not a protected health information environment where we're actually obtaining consultations. So please refrain from using any PHI during this time. This is for education purposes only. There will be information at the very end about CME and CNE, continuing education credits for all providers participating. That will be in the chat, but it'll also be in a slide at the very end. And there's an email address there for you to ask questions. You can certainly put questions in the chat, even if it's a technology question during the meeting. We'll be monitoring that. Next slide, please. We do collect data. It starts with registration and participation, but also questions and answers are all stored. These help us and actually TeleECHO providers from multiple disciplines literally around the world to understand better how to make this education process work better for the participants. So there are a number of reasons for that. Next slide, please. Again, mute your microphone if you're not speaking. Remember to unmute when you do speak. Questions can go in the chat anytime during the open question times. If you'll raise your electronic hand or just speak up if no one else is speaking, that's a good way to do it. Keep your cameras on if possible throughout the presentation. That way we can see who's all here. But if not, we understand. Gallery view gives you the most broadest view of all the participants as possible. Ken's email is there if you have questions or technical issues during the thing. Next slide, please. So again, it's my privilege to introduce Dr. Buchanan to the group again. She's been our stalwart presenter and will continue to help us understanding the value of dermoscopy in general dermatology. She's going to complete what she started last month. And with that, Dr. Buchanan, we'll turn it over to you.
Sounds good. Thank you, guys. So last time we finished, we got through erythema ab igni, which, just as a reminder, this is a type of skin rash that you can see over time through chronic heat exposure. And then it basically resembles this dermal venous plexus, which is why it has this reticulated appearance. Development of skin cancer is pretty rare, but there have been case reports of squamous cell carcinoma and Merkel cell carcinoma. So make sure you talk to your patients about staying away from heaters and lots of electronic devices that could potentially create this side effect from chronic heat exposure. And so that kind of leads me to talk about these patterns of purpura that we can see in dermoscopy. There's been a few case reports and studies in this particular area. So we're going to talk about two different types of patterns: the homogeneous pattern, which is typically non-inflammatory, and then this more mottled pattern, which has variable amounts of inflammation. So this is an example. You guys probably see this every day, and this is solar purpura or actinic purpura. I don't like to say the other name, but senile purpura. So it has many different names. It's basically just a bruise. So what you can see here with dermoscopy is the homogeneous pattern, where you see these red to purple structureless areas, and you really don't see any other features. And so again, this is non-inflammatory. And the reason this happens is because the vessel wall gets damaged because there's increased fragility. These patients are also often on a lot of medications that can increase their risk for bleeding or bruising. And then over time, through chronic sun exposure and just general aging, the dermal support is limited. And so it creates these ecchymoses or solar purpura. And so you do have to be careful, though. My question to you guys are these two the same or are they different? Well, let's analyze these. So the image on the left, you see these background red to purple structureless areas. And then the right, we just went over this, the same type thing. Now, what you also see on the left is this small area that shows an erosion. And then if you look carefully, you can see these multiple fine, thin telangiectasias. Now, you can sometimes see these small blood vessels and vessels as dots on the lower legs. And then again, here you see these background red to purple structureless areas. However, these are very different. The image on the left, this is actually a superficial basal cell carcinoma. We talked about these features in prior lectures. The main two here being the isolated erosion and these fine, thin telangiectasias. You can also see a few arborizing vessels here. And then the right is, again, the actinic purpura. So keep in mind, sometimes you do have to be careful when using dermoscopy. You always want to make sure you use your clinical context. In this case, you can see this was an isolated lesion. Clinically, you can see that erosion. So this is not just a bruise. So type of pattern that we can also see is this more mottled pattern. And again, this is when you start to have variable amounts of inflammation. So this is an example here of what we call pigmented purpuric dermatoses. This type in particular is called Schamberg's disease, which is a progressive pigmented purpuric dermatoses. In this particular patient, what you see are these reddish brown copper colored petechial macules. Usually this is bilateral on the lower extremities. And so what you can see with dermoscopy, you see this coppery sort of red-yellow macular pigmentation, fine telangiectasias, and these well-defined purpuric globules. And this kind of color change that you see has been likened to cayenne pepper. And so this is actually pretty common. Start looking at the lower legs of your patients. You will see this not too infrequently. And so these well-defined red globules and dots, this is the red blood cells that have been extravasated out of the little capillaries. And then you see this coppery red macular pigmentation due to, again, variable amounts of hemosiderin deposition and some lymphohistiocytic infiltration. Contrast that to a more concerning type of pattern, which is a vasculitis, palpable purpura. This also can present as that mottled pattern, but this is going to be more direct damage to that vessel wall, usually small vessels or small to medium-sized vessels. There can be many causes for this. Patients can be sick, they can be not sick. So you can have sick patients, they may present like this in the form of sepsis, or you can have other causes like autoimmune, drug causes, or other lymphoproliferative disorders. What you see here in this example are these blue to purple areas that represent dermal necrosis, and this is due to this erythrocyte extravasation secondary to fibrinoid degeneration of these small blood vessels, and you also have a pretty strong neutrophilic infiltrate. So we've kind of wrapped up a few of the general dermatology rashes and different features and dermoscopy patterns. And I just want to mention to you a few different types of clues that you can use if you think your patient has potentially an infection or some other sort of bug that you want to look closer at. So this was a case of a male who presented with these multiple pruritic papules on his wrist. Now let's take a really close look here because it can be hard to see. But what you can see this small tail, right? I highlighted it in white. That is a burrow. And then at the beginning, you can see this sort of brown triangular structure. That is actually the head of the mite. So in classic scabies, your average mite load is going to be about 5 to 15. So you really need to look carefully, especially if you see these small little papules on the wrist or in other common areas. Okay, so let's kind of go over this. This is the tail. So this is basically like this cloud of smoke. And then you see this brown part at the end, which is likened to this triangular. And this is part of this front part of what we call a delta jet. Okay, so this is your triangle and this is your tail. And this is called the delta wing jet sign. Okay, it is a burrow that ends in a mite. And so you guys are familiar with scabies, but we know it results from this prolonged skin-to-skin contact. These patients are extremely itchy. The female mite creates the burrow. The eggs hatch in 3 to 5 days. Common sites, as we mentioned, the hands, feet, the wrist. You can also see this around the umbilicus, in the skin folds, genital area in men, and the areola in women. And so typically diagnosis is made with a skin scraping, and then you apply oil immersion, and you will look for the mite, the egg, or the feces. This is sometimes just not feasible. You might not have this available. And so we won't go through this, but this is just a picture of sort of the life cycle of the typical scabies mite. And so here, what you see are the mite. There's that white triangle that we talked about. And then you can see that cloud, which is this together is called this delta wing jet sign, also called delta glider, hang glider, delta jet with trail. Okay, and these are just a few more examples. So remember the white trail, that is the burrow that you'll look for. And then the brown triangle, that's the head of the anterior head of the mite. Okay, so another example here where you see that burrow and head of the mite. So look for the burrow. It can help you not only make a diagnosis, but increase your yield if you do decide to do a skin scraping. So the mite is going to be located at the junction between the epidermis and the stratum corneum. So you can see here, that's the head of the mite, which you can see here in this pathology slide. And then you can apply your oil there and do your scraping. So again, there's the burrow, the head of the mite. And then there you go. So this has been reported in several studies, equivalent sensitivity. So dermoscopy of scabies is about 91%. Compared that to the mineral oil prep is about 90%. So, this is especially helpful to me when I go out to the state medical prison where I don't have access to a microscope. Okay, so that was an example of scabies. And so a couple more cases. This was a 50-year-old male. He presented with this raised papule on the tip of his nose, had been there for about 3 or 4 months. No history of skin cancer. You see this hyperkeratotic or verrucous surface, multiple small vessels, some are linear curved, and then kind of a yellow background. So this is an example of a wart. And so we've talked about warts before, but they do have some recognizable dermoscopic patterns. So these are caused by different HPV types. So common warts, usually HPV 1 and 2, and they tend to present as 2 different patterns, filiform patterns or these frog spawn patterns. And then, so I wanted to show you guys some examples of warts and what you can see with your dermatoscope. So here, these are these vessels, they're dotted, surrounded by a halo, and this is what we call the frog spawn pattern. Over here, you can sometimes see these black or red dots. And so these are just multiple dark and black dots that correspond to hemorrhage in the stratum corneum. This is another example of a wart that is in the classic frog's bone pattern. And this is a common wart. You can see it has those vessels with small halo and these sort of papillomatous projections. The filiform wart, these are usually fairly easy to recognize. I often see these on the face, but they tend to have these finger-like projections. And so this is an example here where you see these finger-like projections in this filiform wart. Now, you do have to be careful because this is different from a cutaneous horn. A cutaneous horn often sticks out and is a very hard area of firm keratin. And so that is a little bit different. In that case, you probably will need to do a biopsy to rule out a squamous cell. And so here again, these flat warts, they can present more as just dotted vessels. And then this is another example of a common wart, frog's bone pattern. Here, we've talked about these vessels before, but this is just to show you guys these multiple looped vessels or hairpin vessels that we've described before in different patterns, but mostly in keratinizing tumors, typically squamous cell carcinoma or keratoacanthoma. But you can see this pattern in verruca and then also with seborrheic keratoses. And so this was an example of a wart. This patient had also been sort of picking or scratching at this. And so it actually also has a pattern that we can see with like a prurigo nodule. So you have to be careful because in a patient with a history of chronic sun exposure, it can be very difficult to tell the difference between a common wart and a skin cancer. So ask about the history, ask about the risk factors, and be sure to follow these closely if you decide not to do a biopsy. Last case, this is a 64-year-old female. She presented with this 3mm tan to pink papule on the right lateral side of her breast. She did have a history of breast cancer. So let's take a closer look. So what we see, this is a very sharply defined border. We see these, it's hard to see, but peripheral serpentine radial vessels and these centrally located white to yellow polylobular structures. We've talked about this pattern before. When biopsied, this is classic for a molluscum contagiosum. What you see here is just very zoomed in these Henderson-Patterson bodies, which are these structures here. And so this is another example. You have this round border, sharply delineated. You have this peripheral serpentine radial vessels. We've talked about these before. They are important to recognize because in this case, they do not cross the midline. And what you see centrally are these white to yellow polylobular structures. Remember, we talked about the serpentine radial or the serpentine vascular pattern when we talked about basal cell carcinoma, but usually those tend to be more arborizing and they also cross the midline. So 2 examples here. This is just to showcase a few differences between molluscum and sebaceous hyperplasia because they can look very similar. So on the left is an example of molluscum. You can see those yellow to white round structures are usually central in location. And then with sebaceous hyperplasia, you often have these milky white lobules that are diffuse throughout. And they can have those very similar serpentine vessels. So another example of sebaceous hyperplasia. And then you have this kissing lesion with these 2 very cute molluscum. Again, the central structures are the Henderson-Patterson bodies. And remember, this is caused by a virus. So usually you can see these more commonly in kids, but in the example I showed you, this was a patient who was immunosuppressed. Okay, and we've talked about this before. So I think that's it. I really appreciate you guys giving me the opportunity to finish this presentation because you have your dermatoscope. So I just want you guys to get the most use out of it. And then I will stop sharing my screen and pass this over to Dr. Diamond.
Thank you, Dr. Buchanan. That was most helpful. I think particularly for those of us who are in primary care settings in smaller communities, you wind up getting involved in the in the mite cases from school-based referrals. So the ability to know that we can quickly use these without having to do anything invasive on a kid and be confident about it, especially if you're the first person to declare this is scabies, is very helpful. So thanks for that. Dr. Diamond, we appreciate you joining us today and look forward to hearing from you.
All right, you guys can hear me okay? Let me know. I'm gonna
We
switch
can.
this. Let me make sure you guys are seeing the right screen here. You guys are seeing the PowerPoint, not the notes. Is that right?
There we go. Now you got it.
All right, perfect. Thank you guys for having me today. Here to talk about different skin biopsy techniques just for a couple minutes here. So over the next couple of minutes, we'll talk about why do we even do a biopsy in the first place? What type of biopsy should we choose for a given lesion or rash? And then what tools are needed for each of those. So when do we decide to do a biopsy? So in dermatology clinic, a lot of the time, we want to do a biopsy when the clinical diagnosis is uncertain. Getting the dermatopathologist to look at the lesion in question under the microscope is very important to helping us figure out some of these more confusing lesions. And then even if we think that we know that something is either a squamous cell or a basal cell or a melanoma, being able to characterize it further under the microscope helps us to guide treatment from there. And then sometimes we're sure that we're treating one condition, but it's not responding well to therapy. So sometimes getting extra information by taking a biopsy from something that you've been treating can either confirm that you're just treating something that's recalcitrant to, conventional therapy, or maybe you were treating the wrong thing in the first place and it's a different diagnosis. So what kind of biopsy should we use? So when you're thinking about what kind of biopsy you want to utilize for a specific patient, you have to consider a couple different things. The first would be the anatomic site, and then what type of lesion we're talking about. Is it raised? Is it flat? Where in the skin do we think the important information is going to be? Is it going to be at the top of the skin in the epidermis? Is it going to be a little deeper in the dermis, or even further deeper in the subcutis? And then sometimes, it comes down to patient preference. Some patients are extremely cosmetically oriented, and we'll talk about, a certain biopsy that might be better for those kind of patients as well. So just kind of more along that. On the right here, we're seeing an example of a tangential shave. Both a tangential shave and a deep shave utilize a shave blade. A tangential shave is at a more kind of oblique angle to the epidermis, and when you do a very superficial shave, you're only going to really see the epidermis and maybe the papillary dermis under the microscope. So you want to be confident that the lesion that you're looking at, the information in question is located superficially. We employ deep shaves when we think that there may be more involvement of the reticular dermis or even down to the fat. That's going to come down to personal experience using a shave blade and understanding what kind of angle you need to take in order to get enough information while at the same time not getting too much information. You don't want to leave a patient with, a very deep hole if that's not necessary on the skin. Punch biopsies, we use these a lot for rashes and maybe some more complex dermatologic conditions that we encounter in clinic. This is going to give us a cone of tissue that will encompass the epidermis, dermis, and fat. And like I was saying, inflammatory processes and sometimes even depressed neoplastic conditions as well. And then incisional and excisional biopsies are also options as well. And I'll touch on those here on the next slide a little more. So selection of biopsy type. So I think we utilize tangential shaves most often in clinic. These are used for raised non-melanocytic lesions that are suggestive of skin cancer. We do a lot of these for facial basal cells, squamous cells, and also truncal as well. Generally when we're biopsying a basal cell or a squamous cell carcinoma, we'll be able to get enough information just from the epidermis and part of the dermis. And, even if we transect the lesion at the base, it usually does not change how we would treat that lesion. Now, if you're more worried about a melanoma or melanocytic nevus or even a larger squamous cell, getting deeper into the dermis or subcutis provides us more information. So, a great example of this is when doing a shave biopsy, if you're dealing with something that you think is a melanoma, transecting a melanoma at the base can be detrimental to the patient. because prognosis and also treatment modality is kind of guided by Breslow depth or how deep the melanoma goes. So transecting it actually can hurt your patient sometimes, and oftentimes when they go to surgery, they get upstaged, and it kind of changes how treatment is done. Like I was saying before, punch biopsy, we use this for inflammatory dermatoses or very large cutaneous malignancies. And proper sampling, we can take a small hole and see pretty deep down into the skin there, or even into the sub-Q. Excisional or incisional biopsy, there's a unique place for these. These sometimes larger neoplastic lesions are better done by taking complete kind of gross margins, just with, you just take everything that you can see on the skin. It's great for melanoma. You're using a scalpel and you're going to end up suturing these people up, but you're able to completely control with, I think, the finest dexterity, or, it's better than a shave blade or a punch tool. You're able to completely control your margins. You're able to control how deep you go. Some patients that are more cosmetically oriented, when they have a facial, basal, or squamous cell carcinoma, or a pigmented lesion in question, might prefer this modality, as they're left with a linear scar instead of more circular, sometimes even ragged scar with a shave biopsy. So it's something to consider. I will say it does take more time in clinic to perform these, and it definitely takes more practice to do these properly. So this is something we run into every day in clinic. This is a basal cell on someone's nose. I think this is a great example where using a shave biopsy, a tangential shave biopsy, is the proper technique here. It's a raised lesion. You can kind of shave it flush to the skin. You may transect it at the base, but ultimately these patients are going to need to be referred for surgery anyways. No reason to dive under it with a deep shave. You could even consider a small punch here, but I think a tangential shave is what we would use 95% of the time on something like this. You contrast this with a pigmented lesion like this that's ulcerating. We would be concerned for a nodular melanoma in this case. Doing a superficial shave and just going, flush against the skin, you're going to lose a lot of information at the base of that lesion. So, the best modalities here, this is fairly large. This is a 1 centimeter nodular melanoma. A punch tool, I don't know if that'd be the best here. You either want to do a scoop shave or a deep shave, or even an excisional biopsy here, so that the dermatopathologist can look all the way down to the base of the lesion. You try your best not to transect it, and then we can either dermatology can treat this, or even sometimes, depending on how deep these things go, we refer them out to surgical oncology. So what tools are needed to do a biopsy? I would say first and foremost, if you're going to biopsy something that you think is neoplastic, I really suggest taking a photograph of the lesion. I can't tell you how many times we have a patient show up for excision or Mohs surgery, and these people, it's been a month or two and they heal really well, and it can be really difficult for us to figure out exactly where we're working. So photographs are great. Make sure to consent the patient, of course. You're going to need to obtain proper local anesthesia. We use epinephrine with lidocaine, and we buffer that with sodium bicarbonate. The reason we use the epinephrine with the lidocaine is that it first gives us faster anesthesia. It helps with hemostasis. And then the buffering with sodium bicarbonate also helps the anesthesia act faster, but also for patients, the injection is less painful. And then we'll go into the tools of choice on the next couple of slides. And then for hemostasis, you're either going to have aluminum chloride on hand. These are great for shave biopsies. Suture with the proper tools for a punch, or gel foam for a punch. And if you have cautery at your disposal, that's also good as well, especially for patients, larger neoplastic lesions or patients that are on blood thinners. Having cautery on hand can be extremely beneficial. So let's first talk about a shave biopsy and what we need on a tray. So these are the necessary tools. You would start by cleansing the skin with an isopropyl alcohol wipe. After that, if you have a skin marker available, which I don't actually have on this slide, it can be beneficial to actually mark out your lesion. A lot of times when you're biopsying a smaller papule that's concerning for malignancy, you may obfuscate it when you locally infiltrate the skin with anesthetic. So I think it's helpful to use that whenever you can. And then take a picture, lidocaine for anesthesia, and then you use the shave blade to sample the lesion, have your aluminum chloride on hand, and then finally just dress the wound with Vaseline and a bandage. In dermatology, we do not suggest using something like Neosporin or triple antibiotic. Oftentimes, we find that it does not help with infection risks. Most of these are not going to get infected in the first place, and kind of predisposes the patient to maybe getting an allergic skin reaction afterwards that they think is an infection and can be confusing for an infection. So just plain Vaseline. Punch biopsy. So a little bit different. Obviously, the first steps are all the same. When after you've got anesthesia, you want to use the punch. You're going to place the punch, perpendicular to the skin, and you're going to want to put firm pressure downwards. When you're actually trying to get the core out, you're going to want to twist the tool in either a clockwise or counterclockwise fashion. I would suggest just choosing one of those when you're doing the biopsy, as if you go back and forth, you can actually shear the epidermis from the dermis, and that can kind of make it a little murky for the dermatopathologist as to correlating the epidermis with the dermis there. So after that, there's a couple different options for either repairing the hole that you've made with the punch, or just obtaining hemostasis. We use fast gut a lot of times in clinic, which you can see in the bottom right there. You can also use something like Prolene or nylon. The advantage of using fast gut over a Prolene or nylon is that fast gut is a dissolvable suture, meaning you won't have to bring the patients back or have to give them a suture removal kit. When usually for a 3 or 4 millimeter punch, 1 or 2 simple interrupted sutures will do, or even like a figure of 8, something along those lines. Alternatively, I don't have this on the slide either. You can use gel foam to pack the wound. There's been studies that show that a 3 or 4 millimeter punch, when repaired with suture compared to just packing it full of gel foam, the patient ends up with a similar scar, and patients have similar outcomes in terms of their satisfaction with their scar after biopsy. So something you can employ as well. Patients don't have to come back after having gel foam placed in the wound. And then either with sutures or with gel foam, you're going to want to dress it with Vaseline and a bandage. So pitfalls of the skin biopsy. So depending on where you biopsy something, we might not get the right information, or we might just be missing where the area of pathology is under the skin. If you partially sample a melanoma, for example, and you get the depth of the melanoma from that part, but you fail to get the rest of it, when they go for surgery and they look at the excised lesion in totality, they might see that it goes a little deeper than you really thought, because you just grabbed the wrong part of it. So that's one issue that can happen with skin biopsies. If you have inappropriate technique or poor tissue handling, it can limit your diagnostic yield. Something I forgot to mention on the last slide with punch biopsies, they can be subject to crush injury, especially if you're using forceps that are not toothed. So, you need to have the right tools, tooth forceps. And if you crush it, your dermatopathologist might not be able to get the information they need from the skin sample. And then sometimes it might not actually provide a direct answer. It may only narrow the differential. We learn a lot in residency about different patterns of inflammation, or kind of like how it looks under the microscope, and that can correlate to a broad variety of diseases. So, for example, we have a differential called spongiosis with eosinophils. That's not an answer for us, but it does help us narrow down the differential. So, a biopsy, it doesn't always 100% give you the answer. You have to correlate what you're seeing under the microscope to what you're seeing in clinic. And then finally, sometimes it's best to refer biopsies out to, people who, deal with these more complex things. This is an example of bullous pemphigoid. And, if you haven't encountered this many times, or it's not something you see routinely, where exactly do I biopsy this? What kind of biopsy should I do? Do we need multiple biopsies? And it can be really easy to biopsy in the wrong place, and that can be detrimental to the patient. As even if you send them out, if somebody has a prior biopsy, they may be inclined to just believe it rather than believing there was some sort of sampling error. In this case, if this is a new case of bullous pemphigoid, we would actually suggest 2 different biopsies. It'd probably be a shave of an intact bulla, and then you would want to send that in normal medium, which is 10% formalin. And then we would suggest a punch of perilesional skin to be sent for direct immunofluorescence. So basically, I'm just saying all this to say, if you're seeing something that's really complex and you're not sure exactly where to biopsy, sometimes it's just better to refer out to make sure that we get the proper diagnostic yield for these patients. And that's all I have today. Thank you guys for having me.
Thank you, Dr. Diamond. That's very, very helpful. Appreciate it, and the great illustrations. I also wanted to just comment that I noticed on all your trays, you had a TB syringe with a very small needle, which I think is important. I know in my surgery training, surgeons didn't like to use little needles or little syringes for anything, but a PA actually pointed out to me after I got in practice that my patient satisfaction would be a lot greater if I at least started with that and got it underway. So thank you for that.
Yeah, I think we most often use about, at most, you really just need about 1 cc of that 1 or 2% Lido, and we use 30 gauge needles.
Yeah, I found that even if I was going to have to do a larger area, doing just a few injections with that size needle in a small syringe, you could actually control the infusion a lot easier with that size syringe. So good point. Sidebar to that. Any questions at all for Dr. Davis or Dr. Buchanan? Dr. Diamond or sorry, or Dr. Buchanan? I don't see anything in the chat, and I'm not seeing any hands go up. We'll keep thinking, but I do want to keep us moving. So at this point, we will keep everybody on, but we're going to move forward and go ahead with our case presentation. And I believe the case presentation today is from Andrea Ramirez, who's a fourth-year medical student. And so, Andrea, if you're ready, you can share your screen.
Have to share it. Can you all see it?
We can, Andrea. Thank you.
So, okay, so my name is Andrea Ramirez. I'm a third going into for your medical in medical school. Will be graduating in 2024, just to be more specific. So this is a case of a 50-year-old male that was referred for a non-healing erosion of the right helix of the earlobe. He described the lesion as a tender and it bleeds occasionally. It has been present for over 3 months. He denies any trauma or any history of skin cancer. And I know the lesion is super small, but just wanted to show it where it is located. This is a close-up picture of the lesion, and the dermatoscope findings that we see in this case is multiple white thick lines radially arranged with a central yellow clot or erosion. We also see in our case multiple radiating loops and linear vessels, which are oftentimes not described or in the literature, but I'll go more in detail into that in a later slide. And this is commonly described as a daisy pattern, which is a combination of that central erosion with multiple radiating white thick lines. And I will allude to that in a later slide too. So differential diagnoses for this case are chondrodermatitis nodularis helicus, squamous cell carcinoma, basal cell carcinoma, and an actinic damage or actinic keratosis. Notice that all of these lesions can be found in the helix outer portion of the ear, with the exception of basal cell carcinoma. Oftentimes you see it in the posterior side of the earlobe, but you can also find it in that exterior side of the helix. So for this lesion, we oftentimes, the literature described as a lesion with absent pigmentation and variable vasculature features. One of the hypotheses that sometimes you cannot see that vasculature feature is because during the dermatoscope, when you're pressing against that lesion, you're most likely blanching that vasculature. So even though it's present, you don't see it just because of that reason. So that can be one hypothesis.
And again, it is described as that, white thick lines that is radially arranged with that central rounded yellow-brown clot. And again, barely described as a daisy pattern. And we see a picture in here that is very associated with that. You see that central erosion with that white thick lines radiating. So some of the lesions that sometimes can be hard to distinguish is, like I mentioned, a squamous cell carcinoma. And some of the distinguishing features of a squamous cell carcinoma is that yellow scale with rosette findings and white yellow circles that we oftentimes see. Again, this is just a clear picture of that. So something that is very unique for a squamous cell carcinoma and is that keratin alone, again, is highly sensitive along with those white circles, which are highly specific. The reason why we see this white circles is just is a location around the dilated hair follicle that leads to acanthosis and hypergranulosis of the infundibular epidermis. Again, we see those multiple rosettes with that yellow scale. And the other finding, again, that can be sometimes a little bit hard to distinguish is a basal cell carcinoma. Like it has been mentioned, basal cell carcinoma, we oftentimes see that branching vessels or telangiectasia with that, ulceration we see. And just coming back to the chondrodermatitis nodularis ileus, again, we see that central erosion with those radially white lesions. Sometimes we see the telangiectasia or the vessels, just to be more specific. But again, do not discard just because you don't see the vessels, as oftentimes you cannot see them. This is a benign inflammatory degenerative disease that is present in the external earlobe. Something that is very distinguishable is that it is painful and tender, oftentimes not described with a basal cell or a squamous cell carcinoma. And the reason why this happens is because of ischemia of that cartilage or collagen, and that results because of a combination of pressure, trauma, cold, or actinic damage in that area. Again, it can be hard to distinguish from a squamous cell or a basal cell or an actinic keratosis, especially that we oftentimes see it in that same population that are elderly male with a fair skin tone, and oftentimes in that same area of the earlobe. When you're not sure, then a biopsy is the best next step to make a diagnosis. So some treatment and recommendations, the most conservative ones is, recommend the patient to sleep on an alternative side or use a donut-shaped pillow, which is easier said than done, especially when you're so used to sleeping in that side or using that same pillow. It can be very difficult for patients to just change the position or change the pillow. Another thing is using that adhesive foam, and that's just to reduce the friction that can exacerbate the pain. Other more invasive is topical glucocorticosteroids or injectables that can help reduce that inflammation. And then the other ones can be cryotherapy, protein injections, injectable collagens, platelet-rich plasma, carbon dioxide, laser ablation. And if any of those, they don't work, then the best next thing is surgery, which is just a minimal skin excision with removal of that affected cartilage. And that's it. These are my references. Thank you.
Thank you, Andrea. I'm sorry I didn't pronounce your name correctly the first go around. We appreciate
No
that.
worries.
Great
Thank you.
information, great illustrations. Any questions for Andrea? Okay. Don't see any hands up. There's nothing in the chat. Maybe get some commentary from some of our dermatology colleagues or someone even from one of the clinics about what happens during the summer. Do we tend to see more irritated skin lesions come in, increased outside exposure to the environment, to the sun? Is there anything that we might prepare our participants for in that way?
I will say that actinic keratoses tend to go into hibernation in cooler weather when people are staying inside. And so you'll have folks who will come in during the winter and they'll say, I don't have that much and things are pink and a little scaly, but boy, if they get sun, those things wake up and become very active. So I do think that we see a lot more symptomatic actinic keratoses when people are outside getting more sun than they should.
Great, thank you. What about application of various stuff? Does sunscreen cause some trouble sometimes in addition to protection?
Well, we do see some allergy to some of the sunscreen ingredients periodically. Less so since I think the manufacturers realize that they need to be careful with that. What we see are people missing areas on their skin, so they put their sunscreen on and they miss a spot and then, they come in burnt and always embarrassed when that happens before their dermatology appointment. So I did want to say one thing about the CNH, the chondrodermatitis. Sometimes if you take that spot off surgically, it'll just come back next door because people who get this always sleep on one side. And they'll say, I've got a bad hip and I cannot sleep on the other side. And so I think that's the biggest thing is that it's really hard to get people to sleep on their other side. And that's why you have all those crazy concoctions trying to take the pressure off that ear. But that's a really good, question to ask is, do you have to sleep on that side? And they say, I always sleep on that side, like always. Then, chondrodermatitis is probably your diagnosis.
Wow. That's a good point. Never thought of that.
And as Andrea pointed out, they hurt. They're tender.
All right. Well, so I'm going to turn it back over to Rhea in just a minute, but what I want to kind of remind everyone is that even though we're not going to be having sessions during the summer, for those of you who may, as you start seeing maybe some more of these active lesions come into your clinics over the summer, if you feel like you're a little bit rusty with the use of the scope and all that stuff, we can certainly arrange for, sort of a reskill or a reboot if we need on how to use the scope. We want to encourage you to continue to use those. If the summer is in fact a time when you may actually see more skin lesions, people uncover during the summer, and so they get more sun exposure and things like that. So we may have more of that come in to see you. And if you're not sure that you might need some help sort of reschooling on how to use the Dermoscope, then please let us know and we'll be glad to help you with that. I don't see anything else in the chat or the questions. So with that, I'm going to turn it back over to Rhea.
Okay, thanks, Doug. And yes, I want to emphasize that we will be answering your consults during the summer, that we're just pausing on this educational aspect. So I want to thank everyone who participated today. We had a large crowd here today, which was great. And for those of you who want CME or CNE credit, we have it up here on the screen, and you will also, it's in the chat, and you will get an email about it after today's session. So make sure you collect your CME or CNE credit, and we will resume the TeleECHO sessions on August 7th. So for those of you that are here today, but and that's the time that we see you, we'll have a good summer. We'll see you in a couple months, and enjoy your summer and use your sunscreen and wear your hats and take care of yourself, which I can say, but I'm not good at following that advice. So I have to be better at all of it. So thanks for being here. Have a good summer. And we'll see you in August. And I'd like to remind our TeleDerm Hub people to stay on for a few minutes afterwards, but all of our guests and healthcare providers from the clinics can now sign off.
Bye. Bye.
And we can stop recording.